I'm going to talk to you about a little bit about obstructive sleep apnea, mostly from a practical standpoint. We'll see a little bit of anatomy, but I'm sure you had all this stuff about hypopharynx and velopharynx and all this stuff before. So the purpose of this is to partially entice you to dental sleep medicine, which is actually, believe it or not, it's a field of dentistry where we treat sleep disorders, sleep disorder breathing, with oral appliances. And I'll tell you why we're as dentists, we're the only ones who can do this because we know our mouths, so to speak, right? So you look at some of the literature that's come out in the last few years. More and more people have sleep disorders breathing. Not necessarily apnea, but I can probably from here, a third of you, or a bit less than a third of you, have some kind of sleep disorder breathing. Either insomnia, or you have upper airway resistance, that you have allergies, which in Cleveland, I think we're the second or third city of allergies in the country. Or you have other types of disorders called parasomnia. So we'll go over very, very broadly over those disorders. Now, if you read that slide, it says up to 20-something million of Americans have that. So you're looking into going into business of dentistry, being a niche person in dentistry, and you want to get a good living. This is probably a good way of doing it if you get the training to do it. When you look at this stuff, this is basically just papers from a couple of years ago that talked about what's the prevalence. And I think the prevalence is bigger now because we're better at diagnosing it, not dentists diagnosing it, of course. That's physicians, sleep specialists do that. But we're better at asking questions to people if they have symptoms related to sleep disorder breathing and stuff like that. Now, those of you who are now in finals, right? Type. Okay, so who has no daytime sleepiness as you're sitting in there after 2 hours of periodontal bacteria? Right? So warm room, warm weather, postprandial, wherever you went to have lunch, right? And you have somebody talking to you about periodontal bacteria, gram-positive, gram-negative, endotoxins, exotoxins, okay? And then I come here and talk about sleep. That's great. That's a great closure for the day. But basically, I can tell you, half of you have daytime sleepiness. How do you know? You wake up, you're yawning all the time, right? What is the first thing you do? What is in the corner of Euclid? Starbucks, right? You go to Starbucks, get some coffee with the excuse of breakfast, but really you want to come on, you need to be up. So, increasing prevalence, and even if you look at different ages, and don't worry about those numbers. We'll go over the numbers a little bit. Welcome. Daytime there's a lot of people. So if you get anything from this lecture, and of course I'm going to ask you something about the factoids I'm going to give you, but if you get anything about this lecture, it's how can we tap into this market? Right? As a dentist, how can I get use of the 22 million people? So my dentist, which I'm very picky about dentists, I'm the type of dentist that looks in the mirror when you see a dentist for the first time. I'm looking in the mirror as the person is doing whatever. Because I know what people should do and what people don't do sometimes. So I just look in the mirror and ask them, do you mind if I look in the mirror? And some mind, some don't. Yes?
I don't think we have that PowerPoint available.
You don't? Okay.
It's on the survival guide.
It's not the same one.
So it's a different one. The survival guide is very different. Every year survival is different. This was my courses. As the grad students, they have this course I'm giving to the grad students, which 2 years ago there was a 20-question exam. 2 of them did it in 2 seconds, not 2 minutes. 2 minutes. And you got an A, both of them. So at that point, you have to be really naive to not think that this thing is tested in part of survival guides now. So last year I changed the whole thing and half of them failed. I didn't tell them anything. They said, here's a test proof. Half of them failed. All right. So I can send it to whoever now if you want. I sent it to Heather this morning, but Heather is out today, and I sent it to Dr. So who's that note? You're not there?
Yeah.
That's for you, I haven't even started.
It's bad.
That makes sense. Wired AirPods. My USB drive.
Oh yeah. Where'd I end up? I was back in the camp.
Yeah, they sent out like a one together.
All right, so look at that stuff. So if you look at the treatment for this, we'll talk about it later on. It's quite old-fashioned, and a lot of people don't like it. So that's where we go in. If you talk about kids, you know, those kids that you see that are diagnosed with ADHD and other stuff, a lot of times is because of this. You probably have heard kids snore, right? And a lot of times they have either obstruction or some other type of breathing disorder. So it's getting a lot of attention. This is just 2 months old, a little bit less than 2 months old. And this is one of the, bless you, one of the first people who actually started screening in dental offices. So she only practices that stuff. So she doesn't touch a handpiece. She only does, you know, dental sleep medicine type of practice. And why do we need to be concerned about screening for this stuff? Well, we have access to all the stuff they read there. We have access to patients more than physicians, right? You heard this many times. You know, only you guys are quite young, so you probably haven't been to a primary care person for a while, unless you have a cold or something like that. But you go to the dentist every year, I hope, or every twice a year. So you see all this stuff, and most important, and this is when the rubber hits the road, is that we save money to the healthcare providers and to the insurance companies by screening medically. And that's when they really pay attention to us. You can say everything you want, but if you don't prove that this has some kind of dollar amount they apply to it, you won't really lift off the ground. So the definition of screening. You know, when is a medical diagnosis and we're not, very scientific source, of course, right? It could be worse, it could be Google, you know, but it's a very basic definition of what screening for disease is. Now again, we're screening for signs and symptoms that may lead the patient to the disease. We're not diagnosing, which is a big difference. The diagnosis to be done by a sleep doctor. So you guys are first year, you already have been through multiple lectures at epidemiology, right? With my good old friend Dr. Denko. So you can read all this and have a little bit of nightmarish thoughts. This is quite important because if you don't remember this crap, you're not going to read scientific literature, and some kind of bully no, seriously, some kind of rep will come in with this paper they publish with somebody they pay $60,000 to do the study, and there's no bias there, of course, right? There's no conflict of interest. And they tell you, look at this is sensitivity of 99%, specificity of 99%. There's nothing that has that, I'm making it up. But you need to understand where you are in terms of the definitions. And I'm not gonna teach you that because I'm assuming you know that. But it's quite important to know what are you looking at. If you're looking at something that you want to just go ahead into the Samsung Pavilion or whatever, you're gonna stop every single student on nursing, dental, and medicine and learner, and do a questionnaire. That's sensitivity, so it's population based, right? However, but you know already. You don't know that the patient has a disease. Sorry. When you look at predictive values, you know that the patient has the disease, and you want to confirm if the patient has a disease or not. And that, in our case, it's 25 million people. It's a pretty good prevalence of the disease, close to 10%. Now you think this is new, all these people in oral medicine and saying that we should do all kinds of medical things and IPE, we're gonna do the IPE Midwestern, Gold Blue or whatever. Well, it's been going on for a long time, and actually it's been going on from the medicine side more than our side, where we were tasked as dentists to screen for blood pressure changes in our patients. It only took about 45. So it took probably about 35 of those years to really hit us as far as organized dentistry that we actually can do this stuff and help educate patients and also refer patients when their blood pressure is crazy. And then people were doing this. You saw the screenshot from the lady who's practicing that. It was about 10 years ago, but really hit the first page, so to speak, maybe 7 years ago. That's when the ADA got breath of, okay, well, we are doing this as dentists, and we should probably, the ADA has to have a hand in everything, so they say we should probably be the first ones to do a policy statement and whatnot. And they came out with this stuff and saying that, we as dentists should be screening for patients with sleep disorders. And I put it on small font on purpose because I don't want you to read it, but it says that dentists can screen for sleep disorders. So why are we doing that? I mean, what is our training? Well, I'd like to say you probably have heard me multiple times, and you hear me like multiple times next before you leave here. You heard me say that we're the owners of the neck above. There's really nobody else who knows better than neck above except ENT surgeons than us. That's a fact. Now, if you don't feel comfortable saying that, you're not in dental school. I mean, I would say, how many dental schools are there? 65, whatever, 63, or whatever it's coming out. Probably 50 of them are pretty the same as us. So we make sure that you guys come out comfortable with anything beyond the neck, in terms of pathology, hopefully, in terms of screening for disease, and in terms of recognizing abnormalities. And certainly, of course, the teeth are part of that. So, is obstructive sleep apnea an oral problem? How about bruxism? So, who clenches their teeth here? Right? So, those of you who said that you clench your teeth, multiply that by 3 or 2.5. That's really the amount of people who clench their teeth, because most of us don't even know we're clenching unless we have a spouse, significant other, who tell us. Those of us who know that we're clenching our teeth because we catch ourselves clenching our teeth while we're awake. You're studying for a test, you're studying for anatomy or whatever, and you start doing this. Or you're doing the chewing gum trick. So clenching the teeth was used to be known as, you're just anxious, you're just very, very hyper or whatever. Well, guess what? Now bruxism is called sleep-related bruxism. If you go to a physician's office and they say, I'm here because I feel sleepy, they have you fill some questions that I'm going to show you, and after that I'm going to ask you, do you clench your teeth? Why? Because bruxism is now a sleep disorder. If you heard the term restless leg syndrome, have you heard that? Does anybody know anybody with that? It's very annoying. My wife has that, and it's very annoying. But anyway, our bed is now big enough that I don't feel it anymore. So that's bruxism is classified under the same. It's a movement disorder associated to sleep. And if you look, when we're done with the little physiology, I'm going to give you very simplistic, you'll understand why. Now, how is obstructive sleep apnea treated? Now, if you ask Dr. Qureshi or Dr. Bauer, and there's another oral maxillofacial surgeon called Dr. Clemo, who works in the West Side in Metro, they will do something called maxillomandibular advancement. And if you recognize what that means, it's basically almost orthodontic surgery. They will advance the mandible, and the idea is that when you have apnea, there is simplistically described, there is tissue of the tongue that obstructs the airway. So by moving the mandible forward, you are de facto moving the tongue forward and you're increasing the airway. That's our hopes. So that's the surgical option. Now, how many people will go for surgical option? Not too many. If you tell somebody, oh, you have apnea, they're like, okay, you can have CPAP, or you can have a mouthpiece, or you can do some exercises, or you can have surgery. This is what the people will say first. Surgery, right? No. So, well, some people may, if they're really, really, really desperate, but that would be really bad, anyway. So most people want to try other stuff before the surgery, except if they're phenotype. Remember, again, phenotypes, face, the size of the face, positioning of mandible and maxilla, is really, really, really red flag, and that I'll show you some of those phenotypes here. Now, how about the occlusion? So we have, sleep apnea. Does that affect occlusion? And in some of the pediatric sleep apnea cases, if you look at kids, so you have adults, we do all this stuff, we try to prevent sleep apnea. Why? Because it's very closely related to cardiovascular health, it's closely related to atrial fibrillation, it's closely related to breathing disorders. How about if you get the kids before they grow up and become these adults and have to spend all this money? Same thing that happens with hypertension. Right? Well, who owns the occlusion? ENTs? Dentists, all right? I have yet to meet, and I know a lot of ENTs, and I have friends who are ENTs, one ENT who understands exactly what occlusion is. A very nice friend of mine, a young girl who works at UH. She's a terrific ENT surgeon. She's sleep trained also. She did a fellowship at Pittsburgh. Came here about a year ago, and she and I exchanged patients. I send her my patients who I screen out, and I say, maybe you have sleep apnea. She sends me the patients who fail CPAP and who want oral appliances. And she once sent me a patient who was in the middle of Invisalign. Am I going to put a piece of plastic in the middle of somebody who has active tooth movement? Come on. And I brought that back to her in the consult very, very subtly, right, of course, because I don't want to lose the referrals. And she was like, oops, I forgot about that stuff. Occlusion. And if you talk about kids, it's even worse. You have this mixed occlusion, you have teeth that are loose already, and you always worried about making teeth loose. And you put an appliance, you can have mixed dentition, it's worse. Let's talk about sleep a little bit. So how many hours, somebody here sleeps more than 7 hours a day? All right, so a few people. 13 hours today? So you're probably starting now. Why don't you go? What's the ideal sleep length for an adult? 7 to 9. Now, yesterday I went to bed, I tried to go to bed at a nice time, it was usually 11:30 or 11. It was 12:30, I was still going on the shoes in my iPad. And I woke my puppy, he wakes me up, it's our alarm clocks, our puppy, so he decides he wants to walk out at 5:30. So how many hours of sleep? Or less? Right? What did I do when I got to the office? First thing, coffee. Now, ideal adults should sleep 7 to 9 hours. That's the ideal sleep. Now, it doesn't mean that everybody has to sleep 7 hours, but some people their normal sleep is 6 hours. Now, those people who tell you, I'm not a maxillofacial surgeon, I'm a surgeon, I sleep 5 hours, I don't care. It's bullshit. They can do that when they are 28 years old. 36-year-old, they cannot do that. 40 years old, they will be starting the case and then let the chief resident do the rest and they'll go back to the, because you can't sustain that. You can't sustain it. I had one of my brothers is a internist and he opened a practice in Chicago. Building, he got a loan of, God knows how much, so he just like, okay, he doesn't, crazy guy. He worked 16 hours a day. 16 hours a day. And he made a, boatload of money, sure, I'm sure. He makes a lot of money. He sleeps 4 or 5 hours a day. This is about 20 years ago. 6, 7 years he could do it. Year 8, he got a bad cold, he didn't take care of it, kept on working. Have you guys heard about Guillain-Barré? Guillain-Barré syndrome is an autoimmune demyelination disease that happens when your immune system actually gets confused by an infection, usually an upper respiratory infection that is not taken care of, and attacks your nerve system. So the guy one day woke up and he couldn't walk. Now, 40% of these people actually don't make it. So he was in the ICU and all kinds of nice things for about 3 weeks. And luckily he came through. Now he got some neurologic deficiencies, but he's an internist who doesn't have to operate a lot, so he could do it. But now he works only 4 days a week. And this is, the guy has 52 years old. So, you know, you'll gauge what you need as far as sleep. Now 14 hours is a little bit too much. That's definitely the opposite. You sleep too much, there's something wrong. So maybe you have narcolepsy or something like that. But usually when you have the stages of sleep that you see there, they are divided in numbers. So 1, 2, 3, there used to be 4, and then you have this REM, right? So what does REM stand for? Very nice. So in those cycles that last approximately 90 minutes, you need at least 4 or 5 of those cycles to really rest. Right? Because you don't really rest in the middle, in the beginning, or in the middle. You rest usually in the stage 3 and some in the REM. That's where you really rest. The other stuff is kind of getting yourself prepped to rest. And that's the area where you dream. So if you haven't had any kind of dream in the last month or 2 months, you're not resting. You may be hyper, you may be skipping REM, or something's going on there, or you're waking up too frequently. The sleep pattern of 7 hours, it changes. So when you and I were 15 years of age, we slept, it was normal for us to sleep 4 hours or 5 hours, right? Or in early college, no? Maybe. Now, does that mean that it was healthy? No, because that's when the kids in the morning, and you come to clinic at, or to class at 8, and I can tell you probably until 8:30 you don't remember what they're saying, right? Really good. And when you get older, it's the same. When you get older, you sleep less because you have less hormones. You get less melatonin and other hormones that help you regulate your sleep. So how do they diagnose this? They a lot of questions, and then they send you to a sleep study. And actually, there was this intermediate step. So I was driving from Mentor where my dentist is, and I was telling you about my dentist because he does also sleep dentistry. And Mentor to here in a good day is probably 35 minutes, 40 minutes. Around 25 minutes into the drive. Not good, right? And this is not new on me. I'm about 16 years ago, I had to drive 45 minutes each way to get to my job in Philly. And I fell asleep twice, like hands on the lap type of thing. Wake up when the hands reach the lap and I'm like, wrap the wheel up. So not funny. No, I mean, somebody was driving for me, quite honestly. So after I did that, I recently told my colleague, hey, I think I have sleep apnea. Because I do get, driving, and they ask you about how many minutes. You're watching TV after you go home from here. Let's say somebody go to the gym, some goes to eat in a nice restaurant, some walk around, whatever. Then you get home, turn the TV on. How long does it take you to fall asleep? That's called sleep. What?
Is it the show?
Alright, yeah, okay. So that's called sleep latency. That's a question they ask you when they ask you about this stuff. And sleep latency is between 5 to 8 minutes. Now the show is very good, you know, The Voice or whatever it is. The show is good. Then you may be more. But if you're just watching, you should take about 8 to 10 minutes if you're relaxed. Now if it takes you 20 minutes and you're on bed, like going with this, like fish, you just, you know, get out of bed. It's not gonna happen. You know? But in my case, of people who have apnea, it takes me like 2 minutes. So I have this word for my sofa that if I touch the sofa, it's on my off button. So I sit down on the sofa, turn on the TV, I look at my dog and fall asleep. So my wife is, you know, she's like really, really upset because of that. So I went there and I told my buddy at UH, hey, you know, I probably need a sleep study. He said, oh, why do we use this ring that came out from Hong Kong about a few months ago and it's ready for FDA clearance that apparently can do the same thing as a sleep study, which is the whole, you know, cables and stuff. So I used that ring and I probably had one of the worst nights of sleep because I was flying the next day. And he came up and told me, you're probably mild apnea. So what do you do one of these crap? So this stuff is the sleep study. Sleep study, they basically put a lot of electromyography stuff and they put like oxygen gauges and whatnot. And they can actually measure, if you look at it, this is just a little, they put EMG tracks in your chin. So they can measure how much bruxism you do by doing this. They can measure that. They measure oxygenation, they measure, of course, the brain patterns, because they do have relationship with sleep and other stuff, and oxygenation, of course. They measure actually how much inspiration, expiration they do, and all stuff. So is it an ideal scenario to measure for sleep disorders? Not, because most of them are very comfortable people. But that's what that's used. Now, good sleep is good learning and memory. So when I was in your shoes, I remember I crammed for tests. Sound familiar? So then 2 days before, 3 days before, I went like this marathonian 6-hour type of thing because I needed to get a 3.99999 GPA, right? So I went there and I went there until 2, 3 in the morning, whatever, until one day, guess what topic was it? No, oral medicine. Final oral medicine, D3. So I was asleep. I couldn't wake up to go to the test. I failed the course. Because the test was 80% of the course. And when I got there, they told me, yeah, you can take the test now if you want, but you know, you have to finish it within the 2 hours or whatever you give you. And it was, you know, I had like 40 minutes to do it, so I failed. So I stopped doing that stuff after that. You know. So now you know, I'm taking a board actually in 3 weeks or 4 weeks. I'm taking another, you know, I'll see if I didn't take enough boards, but I'm taking another board. And I know 3 days before I'm just gonna sleep 10 hours, 8 hours, 9 hours. Whatever I studied in this 3 months that I've been studying, that's about it. That's it. So of course we use stimulants, we use all kinds of things to keep us, you know, most of you may have drank a Red Bull at some point, right? I used to do that a couple of years ago until my stomach complained. So I stuck to the caffeine. Of course, if you're having trouble with insomnia, which is the opposite, which is horrible. I mean, if you have insomnia, it's really, I'd rather be narcoleptic than have insomnia. So you take benzodiazepines, you take this stuff also, it makes you regulate your sleep. And most of the time, if you work out, you have most of the time you work out, you have a good night rest. Right? You sleep very well, and that's where you repair stuff that you did yourself. And then there's some data from imaging, that fMRI stuff means imaging that shows how sleep works. So it's heavily controlled by our hormones, melatonin just being one of the most important ones. And we know that the melatonin increases as the day goes by. We do have our changes in airways. So the airway is divided, as you have probably already read or seen in this course, in the upper airway and lower airway. The upper airway is pretty much fixed. That's where you have the nasal airway, where you have the bones in there, and then the lower airway is the oropharynx and below. And that is actually collapsible. So the reason why I can stand in front of you and articulate, and hopefully I'm articulating words, is because of the lower airway in our vocal cords. If we couldn't have that, we would be chipmunks, right? We couldn't speak. But the problem is that if we speak, we need to have very pliable airway. And that means when you relax or you drink, I don't know what alcohol is your preference. Mine is Scotch, single malt. So if I drink more than 2 or 3 scotches, and I always feel my significant other doing like this in the bed because I snore, right? So the airway collapses when you relax too much of the muscles there because they're not fixed, and that's what this means, the impaired pharyngeal control. And certainly you have some genetic diseases where your oxygen saturation, the nadir of your oxygen saturation in the hypothalamus will be lower than other people. So you can actually tolerate hypoxia, which is not healthy, right? But you react to hypoxia much less than other people. And although you will recuperate, you're gonna have problems later on. You keep on doing that in your life. So this is a very simple chart of what happens when you have a collapsible, let's say, upper airway or lower airway. So you may have some obstruction you see there, and that could be either upper or lower. And then what you see here, and this stuff, if you ask somebody to explain that, you have 250,000 different explanations of what loop gain is. But to understand it is basically how quickly you respond to hypoxia. So how quickly your inspiratory muscles will go, right? And any of you has had sinusitis or very bad allergies where you have to use inhalers and steroids, you probably do this a couple of times a night. You're like, right? You spend like 3 or 4 seconds where nothing happens, and if you have somebody who's watching you, they get scared to death because like, he's not breathing, he's not breathing. That happens. So high loop gain is actually not very good. Because that's correlated with increased muscular cardiac issues. So this is a MRI of airway. You can see the differences between healthy patients here, which the airway is tough, right? Versus a patient with increased muscular tone just at the tongue. We haven't even spoken about other tissues, but just at the tongue, you can see how it comes down. You relax your tongue, you have macroglossia, which a lot of us have. So if you stick your tongue out and it has crenations, remember that stuff on the lateral borders of the tongue? Your tongue is too big for your jaw, period. Or your jaw is too narrow for your tongue. But your tongue is not sitting where it's supposed to sit. Ideally, it's supposed to sit in the floor of the mouth, or of course, putting pressure on the roof of the mouth, whatever. But it shouldn't be going on top of the occlusal surfaces of the teeth. If you have pronation, the thing that means you're bruxing and you're actually creating these impressions on the tongue, and the tongue is not comfortable. So that's the main simple description of what happens with apnea. I wouldn't worry about the other stuff. Now this stuff is actually, this stuff here. So AHI, from all that stuff that you do in the lab, and actually I'm going to go and have my sleep study done at the Intercontinental, of course, right? That's the only way I was convinced to go and have a sleep study. The other one's the Marriott over here or something like that. So I'm going to Intercontinental. I'll stop through table 45 before, have a couple of drinks, and go and have my sleep study done. And of course, I'm going to be high AHI. So AHI is outcome measure where they tell you how bad the patient is with apnea. And it stands for Apnea-Hypopnea Index. And it's the number of apneas, and I'll define in a future slide what that is, the amount of hypopneas per hour of sleep. Those numbers will guide us to know how sick the patient is from apnea. And it goes from 0 to 5, from 5 to 15, from 15 to 30. 0 to 5 is very mild, moderate is 5 to 15, and more than that is more severe. Skip that. And this just talks to you about, and I always tell my wife, you know, you want to talk to me about something really important for us and for, you know, for our lives and for our future, especially if it's financial, don't talk to me at 10 p.m. Because I usually start to switch off by 9. Not that I go to sleep, but basically this is not working anymore. I could be doing some autonomic nervous system function, right? But I won't be paying attention to anybody who's talking to me at this point. I'm saying that sarcastically, but really, so this is basically when you go to deep sleep, and this was a test where they did, you know, they'll tell you a nice story, 10 seconds or whatever, according to the minutes, and they wake you up after 30 seconds or less than 30 seconds. You won't remember after 30 seconds. So you're basically kind of already under recharging memory type of function. So what do we ask patients? Again, we're not diagnosing, but we're collecting information from a lot of patients, and we do that with most of our pain patients. We have them fill those questionnaires and also look at their anatomy. So headaches. Hey, morning headaches. You wake up in the morning, you have the worst headache, and you didn't drink the night before. You're either clenching or you didn't sleep well. You didn't oxygenate. The whole night you were trying to catch up, so you didn't rest. I already spoke about the leg stuff. You may or may not snore, but certainly if you snore, that's more of a red flag. BMI goes hand in hand with peripheral resistance. So you have more of lipid content of your BMI, you'll have probably more collapsibility of airway. And so we know that people with 30, 35, 40 BMI, remember the obesity is greater than 30, they're at greater risk. That goes together with neck circumference. So we know females with a neck of 16 inches and males with a neck of 17 inches at a higher risk or greater. We also ask about peeing. So you wake up, again, you didn't drink or you didn't drink a liter of water before you go to bed, and you have to wake up 4 times to pee at night. That's not normal. You're not supposed to diarrhea so quickly, right? You can wake up once maybe. Normal circumstances, again, if there's some kind of drinking alcohol and stuff like that before, it's different. And for kids, they wet the bed a lot. So those are the 2 terms for maturia, how many times you wake up to go to the bathroom, and for the kids, if they wet the bed a lot, that's a red flag. Certainly the daytime sleepiness that I said before. And this slide is basically the definition of apnea, hypopnea, the AHI index. And this you can forget about it, don't worry about it. But those 3 you probably should know that for a test or something like that. If they ask you, somebody asks you, for example, what is apnea? What is the definition of an apnea? You can see that there. So basically you have almost no breathing for at least 10 seconds. Hypopnea is a significant decrease in the amount of oxygen or breathing that is accompanied by what we call desaturation. That's basically a decrease in oxygen. And a combination of this makes the index. So let's go into comparison. On the side of your left side, that's a fairly normal anatomy. So you have, again, upper airway is not very collapsible. You have the turbinates. But for those of you who had polyps in the nose and stuff like that, those get obstructed very easily. I can tell you most of us don't have a straight nose anymore for multiple reasons. Trauma, whatever. Operations, all kinds of stuff. So you have deviations, you have different anatomic changes, and however, that's not a collapsible anatomy. You can still breathe, right? So I have a collapsed valve here in my right nostril because of a surgery of a fractured nose. So I have to use, not to sleep, but when I work out, I use this little thing that opens my nose because it kind of replaces my valve. And I can breathe a little bit better. My left nostril is like 85%, my right nostril is 70%, like that. So it does make a difference when you open it. And here, this is basically the glossal space that is mentioned by the tongue. However, remember, we also have the uvula. So when you're looking at your exam and you see this patient that has a uvula that goes down, and you never see where it ends, red flag, right? Uvula is touching the base of the tongue. Actually, physiologically, that causes sympathetic stimulation, just the contact of the uvula with the base of the tongue. And if you remember what sympathetic system does, right? Stress. I'm always hyper. Why do I have to do now? I have this now, blah, blah, blah. And you can't be too long at that before you kind of crash and need to rest for a long time. And then you can have obstructions even down here, anatomically driven. This is just a description of how the BMI can affect. So the distribution of fat, especially in the head and neck, can affect the airway, just because of the distribution of weight. For those of you who are orthodontists, this is ortho 0001, right? So we look at the position, and I'm not an orthodontist, but this I know how to do. Look at the position of maxillary mandible. And they are normals, right? So they're normals, there's this X-ray that is called cephalometric, and there are normal angles with different landmarks. But in their normals, population based. So you have the angle, and then you look at the table, or the computer who tells you. It'll tell you if the patient has either the maxilla too advanced, or the mandible too protruded, or the mandible is too small, or not. If you add to that the position of the thyroid, where is this? Yeah. No, this is the actual yeah, so the one at the top there, you can check the position of the thyroid bone and the angle that it does with the point of the mandible you see there. And that's related also to risk of apnea in certain individuals. So, of course, we look at teeth. You remember overbite, overjet, all the stuff that you are training how to look at. And of course, if we have an increased overjet, that's another red flag. Why? Because when you're doing your appliances, you're gonna have a risk that we always tell patients that we can move teeth without, it's on purpose, but we can move sometimes teeth. So if you have a retrognathia, like it says here, where it's a little bit further back, that's another risk factor. If you have different face, I don't know if you've seen the types of faces, you have square around, and the names are called brachycephalic, dolichocephalic, there's other name for that. So you have the dolichocephalic face, and I'm going to show you a TV actor. She has a very long face. The actual arch of movement of the opening of the jaw is very different than if you have a square face person opening the jaw. Why? Because in the long jaw, a long face, you're going to open, and at some point you go forward, backward, I'm sorry. And that's very important for us to understand 3D wise, because when we put our appliances, we need to control for that and really be aware of that before we send the patient back to the sleep talk. So we spoke about weight, and we know that it definitely is related to cardiovascular issues. So it's known that people, when they use CPAP, their hypertension gets better, their cardiovascular disease gets better. Atrial fibrillation is a major arrhythmia that they get better. And we know also there's some association with this stuff, with hormonal changes. So what's wrong with the kid and the guy over there? What's wrong with the pictures? I mean, here it kind of tells you, right? Very small mandible. Very small mandible. It's almost no mandibular angle here, right? So a protruded mandible is definitely a red flag for somebody who may be complaining of those symptoms that you spoke about. Look at this thumb, huge. Plus it's furrowed, so when you have this thumb like this, that you actually can spread it a little bit longer, it's worse for the patient because they can, some can control that, but it basically will land up on the occlusal surfaces of the mandible. This is a tongue that is fairly okay, it sits there, so you still can see it, in spite of this malocclusion there, it sits there in the front of the mouth, and it's not really that effective. So we look also at other soft tissues. So you remember the palatoglossal arch, palatopharyngeal arches of our pharyngeal area. When you have the patient opening their mouth without saying ah, so forget about the ah part. Just have them open their mouth and have them breathe. This is what we look at. again, without saying, yeah, of course, if you have somebody stick your tongue out and say, you will hope you can see this. But somebody who's physiologically stable, normal, and they just open their mouth, you'll be surprised how many people have this. Now the normal should be 1 or 2. That's the normal. That's when you see some that way. These people, they have increased tonus of the tongue, floor of the mouth, malahide muscles, genioglossus, and they still can open the airway. Imagine what happens when this relaxes and they're sleeping. You know, and we're not dogs. We don't sleep like, people sleep, they open their mouth, but the tongue doesn't flow out, right? So it has to go somewhere, it goes back. So some examples, you have a pretty good airway there, okay. This one is not very good, and this is hard, look at that. Absolutely no airway, you will be hard pressed to look at a tooth with that tongue. Oh, we also look at tonsils, so if you know where the tonsils are, that's the horizontal part, right? So you can classify many ways, 1, 2, 3, 4, but anyway, you want to make sure that there's some airway between tonsils. That's why with kids, the first or second things that are done from a surgical standpoint, the ENT docs, they take tonsils and adenoids out. That's one of the things they recommend for apnea kids. So if you add to that you have some people can get a lot of I don't like psychological, but I would say stress-related issues that affect how you rest and your position, right? So you can have, if you're under stress for many days in a row, at some point your HPA axis will give up, right? So you'll probably have a little, collapse. You'll have a little, fainting episode or something like that. You may develop a little bit of an arrhythmia. But psychologically, remember, this is not only physiologically in the HPA axis. You have this little thing that we carry on our head, on our necks, also suffers. So you'll get with increased anxiety, increased stress, you'll get this stuff. And basically you're either setting, the rumination is thinking about something over and over and over again. You can go into compulsion, right? Anticipation is you got something that, for example, I used in my previous life, I used to do a little bit of martial arts, right, for 9 years. So in one of my competitions, that was my nose job. So I got a nose job out of that competition, right? And my left eye closed. And my sensei told me, you have to go out. But I went, I didn't know any better. I was 16 years old. I said, I want to finish. And I actually won the committee there with one eye and one nose type of thing. The nose stayed with no nose. But, anticipation. So every time I went to committee after that, every time I was like, I'm gonna break my nose again. And that was the whole anticipation of that. So that was the beginning of the end of my martial arts career. Then I went into dentistry. So, insomnia. Insomnia is pretty, it's almost the same as prevalent as obstructive sleep apnea. And it's related to a lot of things depending on the patient. The definition is there, but with insomnia you'll get a lot of comorbidities. Again, with insomnia you'll get parasympathetic and sympathetic activation. It should not happen when you're asleep. You should have 6-7 hours that you should be letting go, not doing any kind of stress related. And then you have a lot of risks. For those of you who are epidemiologists or fans of the odds ratio, that basically tells you compared to a healthy individual, how many times more is the patient who has insomnia at risk for that stuff. You can tell for us, for example, diabetics, they're bad disease to have. Not only is a periodontal disease and actinomycetes concomitants, right? But also people, in my case, that I treat with this stuff, I have to make sure I'm not cheating their sleep with my medication and the drugs I push on them, and making sure they sleep well at the same time. This is totally opposite. So this is the person over there who slept 14 hours. You probably have some of this. And you can have cataplexy, basically when you're laughing too hard. You remember the last time you laughed a lot? Yes. You lose control of your body movements. At some point you're like, I can't really control my muscles. That's cataplexy. So you can have that without, and you can have also sleep paralysis. So sleep paralysis, luckily, that's what kind of stops us from acting on our sleep, right? So you're sleeping and you're hitting somebody in the head, you don't act on it. Most people don't. My father-in-law did that to my mother-in-law a few months ago. He actually hit her in the head to sleep. So that's a loss of control. That's that phase of sleep paralysis. And that's related to protective mechanisms that allow you to dream. These hormones, this is the same one, orexin, appropriating, they control your sleep and appetite. So when you have a lot of orexin, it will make you eat more. Leptin is the opposite. Leptin is another hormone that will actually control, will make you feel more full. And believe it or not, some people have this all whacked up. I'm probably one of them. Because they'll eat, and then they're full. Right? And then you eat too much, it will affect your sleep as well. And finally, very, very briefly, you have this stuff called parasomnias. There are other changes in sleep pattern. Sleepwalking, the leg syndrome, and bruxism may also be included in that parasomnias. And this is just a more scientific report of the parasomnias. As you can see, there are many, many types of sleep disorders, not only apnea, but they may affect your patients as well. All right, so the nice part. So I had this good friend of mine who we actually went to a sleep meeting of all places that was happening in Baltimore 2 years ago. And guess what? The guy has obstructive sleep apnea. So I was like, I took my little plugs, earplugs just in case. Because we were sleeping in the same room. And the guy came in with his little box, took this thing out, which scared me to death. But anyway, he took that stuff out, he put it on, and actually his CPAP was really nice. It didn't sound, it had no sound. Just put it on, press a button, that's it. So no problem at all. But you can see how this can be a little bit uncomfortable to some people, especially if they sleep on the side or they like to go around. You actually have this tubing around, not around your neck, but here, but there's tubings around. And you have the mask, you can have a nose pad. Some people don't like the mask, so they try the nose pads. You can have a small nasal type of thing here, like a nitro soft side type of thing. So there are many ways of trying to get the patient comfortable with this stuff. There is also an issue of moisture, so some people complain of dry mouth with this, they complain of dry nose, they can't really tolerate that stuff. And certainly when you see the sleep doctor and tell you have sleep apnea, they tell you all the bad things that can happen with sleep apnea, you get all scared, they'll tell you you have to do this lifestyle issue, you have to do more exercise, and definitely weight loss will decrease your risk for apnea. What this stuff does, it pushes air, it forces air. So it's 100% effective. Why? Because you're putting a hose in there. Of course, you're physically pushing the collapsible airway out of the sky and getting the lungs supposedly filled. So a lot of my patients say, well, I tried that for 2 or 3 weeks, and guess what? My tummy went like this every time I had the CPAP. It went around too, right? Another guy, he put on that stuff and he got so dry, he woke up because of the dryness. So he got excellent control of the apnea, but the dryness just woke him up every time. So you have 10 people who you prescribe CPAP, and it's covered by insurance 100%. Again, not us, the sleep docs. Of those 10, 5 from the get-go are going to say, no way. So my wife is one of them. I'm convinced she also has sleep apnea. And she's being like marginal on the test. She already told me, I'm never going to use the machine. So either you make a mouthpiece for me, or I'm just going to die 10 years before. Whatever. Right? That's what she said. So 5 people are going to say, I'm not putting that stuff on. I just can't sleep with that stuff. Of the 5 who tried at 3 months, 2 are going to say, I can't take it. So you're going to have almost 7 people who never use the appliance. who are still sick, who still have apnea. Do you have a better business model to this? Just putting my business out there. Where there is a niche where you guys, us as dentists, are the only ones comfortable with this stuff. Now, it's so good that there's a company called Somnomed, I don't know if you've heard it or seen it on TV or whatever, that trains ENTs to take impressions for mouthpieces. They train them to take the molds and how to take the anterior bite registration. Why? So there are no dentists in that area who can do that or are comfortable doing it. So, food for thought. So those 7 people, and I feel bad for my colleague because I do send her a lot of patients. So I send her at least 3 or 4 patients per week. They go, you know, her name is Amy, and Amy has this patient who I wanted to see, blah, blah, blah. She has this, daytime sleepiness. Her, you know, there's a scale we use that's called the Edwards scale. And she ranked high on that, whatever. And then the patient comes back to me 3 weeks later for an appliance. So I feel bad because I send her business and she comes back to me because the patient didn't want to try the CPAP, right? So she hasn't caught up to that yet, but she's on her way. And what I do is basically I put my patients on the mouth appliance and I send them back to her. So she's comfortable that I'm not taking the patient and running with the patient. So people don't tolerate the CPAP, BiPAP, and there are other combinations of that. They don't want surgery yet. They're very, very narrow mandible. They may have occlusion that is weird. And we know that from limited studies, not a whole lot, but we know that they have the CPAP and the mouth appliances may have similar outcomes if the patient is compliant with the mouth appliance. And it's definitely useful in mild, this is the Russian pronunciation of mild, and moderate OSA. If it's severe OSA, it's not really that good for the mouth appliance. So I'm going to show you some stuff which our group came out with from different universities there to screen patients. So what are we going after is getting an algorithm that we can apply in clinic. Now this is still in the beta version, how we call something that is still very, very green. But we want to put something, for example, in Axiom, just to give you more work to do, right? So if you go to University of Las Vegas, that's already an Axiom. But no, we're shortening the medical history that we have. So we look at these questionnaires, and this is called a stop-down questionnaire. It's a very well proven questionnaire that it works to screen people who have risk for apnea. Then we talk about medical history. Again, risk factors for medical history. You see there's a bunch of them there. They want to, again, this is our field, so we look at soft tissues, and that's what I'm telling you. The other day we went to the sleep disorders grand rounds. They have grand rounds every Tuesday across the street here in Boulevard, and they had an ENT fellow talking about tongue. Excuse me? Why are you talking about tongue? We're supposed to be talking about tongue. Your ear, nose, and throat, buddy. Right? But why are they talking about tongue? Because no freaking dentist want to go and talk about tongue before them because they were afraid that okay, so this is ours. Tongue size. Uvula, subpalate, you can read all that stuff. Pharyngeal narrowing. There's some examples here of the pharyngeal stuff. We kind of went over that already. See his crenations there, big tongue. Tongue tie is a major thing. I have a friend who does something called linguodontics, and I thought he is a me, right? He lives in Singapore. He came to Boston. We were doing a training in this stuff, and he's like, you know, I can move teeth in kids almost orthodontically with tongue exercises. Really? Sure. So he showed 2 or 3 cases where he did it. So either he mounted the case perfectly and he is the perennial, Houdini, or he knows how to do this stuff. And the first thing he does is release all of us, please don't try to experiment now, should be able to touch our roof of the mouth with our tongue without closing completely, like 40% probably. If you feel too tight or that you can reach the roof of the mouth? Your tongue tied. Your tongue tied, and it's you can see this way. In tongue ties, if you do, again, don't do it now, but if you stand up, do like this without the tongue on the roof of the mouth, somebody pushes down, you can support it with these muscles, of course, right? But if you put your tongue on the roof of the mouth, you're gonna get more strength. It sounds crazy, but it's true. Because it will increase your strength of the neck and all this stuff. So, you look at tongue tie now. How many people look at tongue ties from ENT? How many people look at tongue ties from physicians? Nobody. This is Malampati score. Soft tissues, we even look at, this is the whole tonsil stuff with the plane there. One of my colleagues is a prosthodontist, and you guys know prosthodontists? So with permission to speak freely, yes? They're the most anal dentists that I've known, in a good way. Because they need to be. They need to be to do the magic they make, because I've seen stuff they make. I'm so glad I'm not in cross. Good for you guys. So they look at details very, 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 very closely, and they really, really harp on small details. So this guy actually was looking at the angle of the tongue with the soft tissue there. Now, do we need to get to that part? Maybe, maybe not. This is the tonsillar stuff. Look at that. You think that person's going to snore? You bet it will. You bet. A little bit of anatomy, so you get, this is the anatomy. Next. And then the teeth. So as I told you, my colleague in ENT sent me that stuff, and he's like, what do you want me to do? The tooth is moving. I can't put them out. Right? If you see this stuff, grinding. Tori definitely will not have space. So if you have huge mandibular tori, I have tori in my mandible, they're not as huge. That takes a lot of space from the tongue. And then the arch length in horizontal. So some orthodontists actually, in adults, so you guys have heard probably of the palatal expansion, rapid palatal expansion in kids. That's the thing that orthodontists do when the palate has not fused yet. They actually open the upper arch so they can actually move teeth on the bottom and boom, boom. Nice, right? Well, there is some, it's not the same orthodontists, but there's a group of orthodontists, especially out of California, Stanford. They do it in adults, so they actually, it's called SARP, surgical assisted rapid palatal. The surgical part is that you go, not them, but the maxillofacial surgeon goes and opens the suture. And they open the palate, and it's worked for some of the apnea cases because it allows more space for the tongue. Just doing that. And this is the type of face that I was telling you about, dolichocephalic. You can't get more dolichocephalic than that. Isn't it either? Right? Again, flat angle, those are red flags. That's the angle of the thyroid thing that I was telling you about. Okay. And this is what I was telling you about positioning of the mandible. So the idea is that we're trying to use this stuff, and of course it's not user-friendly yet, as you can probably tell. But we're trying to use this stuff as a screening algorithm, and hopefully pilot it in some of the schools that you saw on the screen, and at some point get to maybe a pager, or a little bit less than a pager, where we as dentists can look at this patient, and besides the questions that are asked in the stop bag, look at the anatomy and tell this patient, you're at risk for sleep apnea. And at the same time, we're doing us a favor because we already know, by doing all this exam, we know they're going to be a good candidate for mouthpieces. Right, so if they are already a good candidate for mouthpieces, we can just put a note in the chart, and when and if they come back from the sleep doc, they can use the mouthpiece. Now the theory of mouthpieces, there I give you some examples, and the theory is that you use the maxilla as an anchor. You have this acrylic, an acrylic base or whatever, and you use the mandible with some type of device. In this case, it's a little fin or whatever. We call that the dorsal. Very original, right? And you have a screw here, and the screw is going to push this part of the acrylic up here, and it will hit the fin, and the fin will advance the mandible forward. So that's a very popular one called a dorsal, and then you have different ones. This is a HERFS. This is something that orthodontists used a lot in orthopedic movements in kids. But regardless of the appliance, you have to basically select it based on the phenotype of your patient. If any of you is interested in this a little bit longer, there are now training programs. We're going to be the second dental school to have a mastership program in the country, probably the second one in the world, where we're going to train dentists to do this stuff. And the membership to this stuff, the American Academy of Dental Medicine, is free for students. So you at least have 3 years of free membership, and you can go to the meetings at a reduced cost. Next meeting will be at San Antonio in a few months, 2 months. So you like the Riverwalk? Welcome to it. We're also doing research there. If any of you has interest in research, not this semester because we're all going to move to the new castle we're going to habitate or whatever. But later on, we can be happy to work with you guys. All right. Any questions? I'll be here in a couple minutes. Thank you.